Okay, everybody's coming in.
Good afternoon, everyone. Welcome to another week of CRCR. My name is Natasha Caballero, for those of you who did not see me before. And today we're gonna be covering Unit 3 specifically. We're gonna be doing sections 3.5, 3.6, and 3.7. And so section 3.5 talks about claim form requirement, edits, and EDI. In this section, we will discuss the requirements for basic claim forms, edits to the claim forms, and the benefits of electronic claim submission. Claim processing includes all activities required to send a request for payments to a third-party plan for payments and of benefits. The healthcare industry has developed standard claim forms that must be used for claim processing. The standard hospital claim form is a UBO4, and the standard professional service claim form is the SMS 1500. The UBO4 claim form contains 81 form locators and is used for submitting claims by institutional providers such as hospitals, hospice, rural health clinics, skilled nursing facilities, etc. CMS 1500 claim forms contains 33 form locators and is used by non-institutional providers such as physicians, allied health professions, certified registered nurse anesthetists such as CRNAs, home health agencies, medical equipment suppliers, etc. These are used again to submit claims for services to payers. Both UBO4 and CMS 1500 paper forms have been translated into electronic forms. Electronic data interchange, or EDI, is the technology used for translating, standardizing, and sending transactions electronically. The electronic version of the UBO4 is called the 837i, and the electronic version of the CMS 1500 is called 837p. Using the standardized EDI format, both hospital and professional claims can be set electronically and will include all of the same data elements as the paper UBO4 and the CMS 1500. The electronic data set also includes more information that is represented on the paper form and is organized in groups called loops and segments. The benefits of electronic submission are as follows. The submission, receipt, and processing of the claim is automated, thereby eliminating mail time and reducing data entry time at the payer. The system editing functionality reduces the time spent when a claim is rejected, returned, and resubmitted. Providers can electronically monitor receipt of claims by payers, eliminating delays caused by filing transmission failures, use of unsolicited 276, 277, and automatic claim monitoring can eliminate lost claims and unproductive staff touches. Online claim adjudication can be performed with a provider receiving the adjudication result in real time. And this enables the provider to accurately collect patient liabilities at the time of service based on the actual adjudicated information. Finally, payment turnaround is minimized as claims received electronically are quickly processed for payments without manual intervention. A clean claim is defined as a claim that is sent to a payer either electronically or on paper that has no defect, impropriety, or particular circumstance requiring special treatment that prevents prompt payment. Providers should attempt to receive the highest clean claim rate. Best practice being 95 to 99% of all claims require no staff touches by putting robust edits in both their HIS system and their clearinghouse. Prompt payment can be defined by payer contracts or state or government rules. A summary of the source of data is provided on the next screen to highlight the importance of the patient access rules in processing any clean claim submission. Patient access has a significant role in ensuring that the UB04 form is accurately completed. A summary of the UB04 source data are the following: 40% patient access responsibility, 32 form locators related to demographic and insurance data gathering, 11% service or ancillary department responsibility. That's 9 form locators related to charging or time of service documentation. 20% is health information management or HIM. 16 form locators related to coding or services or documenting chart information. 20% is billing office or system generated, and that's 16 form locators completed as applicable during the post-encounter process. Last but not least, 9% is reserved or not used at the time, and this would be about 8 form locators. CMS 1500 source of data summary. 53% patient access responsibility, and that would be 30 items. 14% service department or provider responsibility, and that's 8 items. 7% health information management, HIM, and that's 4 items. And then 26% billing office or system generated, and that's for about 15 items. There are 4 code sets that provide health plans with additional information as they review the claim for payment. Condition codes are used by the provider to describe conditions or events that apply to the period being billed on the claim. For example, if it's employed related, then code 02 should be listed. Occurrence codes can provide additional information pertaining to the period being billed on a claim. Again, if employed related, occurrence code 04 with the specific date of the accident would be listed. Just as the name implied, an occurrence span code would be used for an event that spans a period of time. If a portion of a patient's inpatient stay was considered non-covered due to a level of care, a span code of 74 would be entered with a specific to and from date. Last but not least, value codes and dollar amount represent data of monetary nature. A common code is 01, which denotes the most common semi-private room rate in a hospital. Claim edit rules developed to verify the accuracy and completeness of claims based on each health plan's policies. Data sources for these rules are Medicare and Medicaid bulletins and manuals, individuals' health plans, manuals, and contracts, and other documents routinely provided by health plans. The claim editing process lets provider identify and resolve claim issues to ensure claim submission to the health plan. This process will result in prompt payment, reduce account receivable outstanding, and increase cash flow. So the current version is 1510. And this promotes implementation of electronic transaction and achieve cost reductions and efficiency, improving by creating more uniformity in the implementation of standard transactions. I always say, however, there's no standardization in the HIPAA standard. There's more work to be done to ensure consistent adoption and application. Council for Affordable Quality Healthcare, or CAQH, was named by the Secretary of HHS as the authority entity of healthcare operating rules. 130 organizations, providers, health plans, vendors, government agencies, and standard-setting bodies. And their goal is to ensure that detailed real-time response becomes the standard for claims-related healthcare. Benefit of electronic claim submission. The submission, receipt, and processing of the claim is automated, thereby eliminating mail time, reducing data entry for the health plans. The system editing functionality reduces the time spent when a claim is rejected, returned, and resubmitted. Providers can electronically monitor receipt of claims by health plan, eliminating delays caused by file transmission failures. Online claim adjudication can be performed with a provider receiving the adjudication result in real time. This enables the provider to accurately collect patient liabilities at time of service based on the actual adjudicated information. And finally, payment turnaround is minimized as claims received electronically are quickly processed for payments without manual intervention. And we're up on our first polling question. What are claim edits? So take a moment to answer this question. And we can go ahead and see the answer next. Wow, 100%. Great job, everyone. So the correct answer is number 1. Data sources for these claim edits rules are Medicare and Medicaid bulletins and manuals, individual health plans, manuals, and contracts, and other documents routinely provided by health plans. The claim editing process lets provider identify and resolve claim issues to ensure clean claim submission to the health plan. Great job. And so as you move on, please keep in mind the following points. The purpose of using claim edits is to verify the accuracy and completeness of claim based on each health plan's policy. The process will result in prompt payment, reduce accounts receivable outstanding, and increase cash flow. Other points to keep in mind include that there are basic claim form requirements for the UB04 and CMS 1500. A clean claim is free from defects, improprieties, or particular circumstances requiring a special treatment, and that prevent prompt payment. The electronic data interchange, or EDI, is technology used for translating, standardizing, and sending transactions electronically, and that there are a number of benefits of electronic claim submission, such as electronically monitoring receipt of claims by health plans, eliminating delays caused by file transmission failures, among others. So next is Unit 3.6, and we're going to be covering here basic billing rules. At the end of this course, you will be able to apply the basic billing rules for major health plans, discuss the basic billing rules and payment methodologies for rural health, hospice, skilled nursing units, ambulance, hospital-based physicians, and clinics, and explain the purpose of billing components, telehealth billing, service billing as well. So there are unique billing requirements based on different third parties and provider type rules. In addition, some health plans may demand additional information before paying a claim, such as an ED report, history and physicals, therapy notes, operative reports, and discharge summaries. The good news is that there are some commonalities in the requirement. A day begins at midnight and ends 24 hours later. The day of death, the day of discharge, or LOA are not counted as days. If admission and discharge or death occurs on the same day, the day is counted as one inpatient day. Providers typically submit a single claim or an inpatient or outpatient episode of care or a series or recurring claim for things like therapies. In certain circumstances, the provider may elect to submit an interim bill, typically used for extended inpatient stays, and can usually submit every 30 days. Timely filing for Medicare is within 1 calendar year of the date of service or discharge. Claims received day 366 or beyond will be denied. Health plans will establish their own timely filing criteria and are generally noted in the contract. We will expand on provider type billing rules in the next few slides. So rural health clinic, UB04 or the A37I is the standard form. Services are rolled up into revenue codes like 520 and 522. Each state's Medicaid plan defines how it will pay for the services provided at an RHC or rural health clinic. Therefore, Medicaid billing for RHCs is often a unique and complex story. It is important to contact the state Medicaid office and obtain basic information on its billing requirements for RHCs. Hospice. So hospice services are generally for terminally ill patients and are provided by an organization or an agency that's primarily involved in providing care to terminally ill individuals. Covered hospice services are nursing, therapies, medical social services, physicians, counseling, DME supplied, home health, and short-term inpatient care. There are two statutory exclusions from coverage: services deemed not reasonable or necessary, and services that are considered custodial care are not covered. It cannot involve the limitation or liability under the COB assignment, payable and understate or federal workmen's compensation, not certified to be terminally ill, and already received 210 days of hospice care. Hospice benefits from a Medicare patient in a SNF cover the professional fees, but not the room and board. Except for physician services, Medicare reimbursement for hospice care is made at one of 4 predetermined rates for each day of care. 4 rates and are prospective rates, and there are no retroactive adjustments other than the statutory cap on overall payments and the limitation of payments for the inpatient care. The rate paid for any given day varies based on the level of care. Levels of hospice care. Routine home care is paid per day regardless of the volume or intensity of the service, and it is also paid when the patient is receiving hospital care for a condition unrelated to the terminal condition. The continuous home care is divided by 24 hours to obtain the hourly rate. Payments for respite care may be made for a maximum of 5 days at the time, including the date of admission, but not including the date of discharge. This payment to hospitalize the patient for a short period of time. Day 6 and beyond are paid at the routine home care rate. Inpatient is paid on a various level of outpatient care. Overall payments made to a hospice are subject to a cap amount calculated by the MAC. Any payments in excess of the cap must be refunded. Payments to a hospice provider for an inpatient care are subject to a limitation on a number of days of inpatient care furnished to Medicare patients. If the MAC determines that the inpatient rate should not be paid, the hospice provider will be paid at the home rate of the home care rate for those days. Skilled nursing facility, or SNF. Coverage for extended care services is a basic part of Medicare Part A. To qualify for coverage, the patient must have received medically necessary inpatient hospital services with a stay of at least 3 consecutive days in one or more hospitals, must be needed for a condition that the patient was treated during the patient's qualifying hospital stay in a skilled nursing facility is covered if all of the following 4 factors are met. Requires skilled nursing services or skilled rehab services, requires skilled services on a daily basis. Daily skilled services can only be provided on an inpatient basis, and ancillary services are available if needed on an emergency basis. Covered services include room and board, therapies, medical, social services, and drugs, as well as biologicals and DMEs. A patient is eligible for 100 days of care in a benefit period. As long as the patient is entitled to Part A, there is no limit to the number of benefit periods they may have. A benefit period is synonymous with a spell of illness. Payment under Part B for clinical diagnostic tests can only be made to the entity that performed the test. For a SNF to furnish clinical lab tests and be covered, it must have a valid Clinical Laboratory Improvement Act or CLIA certificate. A CNF is permitted to bill every 30 days and must be submitted in a sequence. If bills have been submitted for Part B, inpatient services on a bill type 22X, a no payment discharge bill is still required. This is necessary to maintain the beneficiary's utilization record. Ambulance services are billed directly to the health plan for bringing the patient to the hospital for admission and a discharge to home or another facility. When inpatients require a particular diagnostic or service during their stay and the hospital lacks that particular service, then they are responsible for ambulance services. Both the ambulance charges and the services at another facility are billed on the inpatient stay to the health plan. To make sure that the ambulance suppliers don't charge the health plan directly, claims are edited to screen for ambulance charges that are to be bundled into the hospital payments. They can be paid under 4 methods: all-inclusive base rate with separate charge for mileage, base rate to include mileage but charged separately for supplies, or base rate with separate charges for supplies and mileage. It includes oxygen, drugs, extra attendance, and EKG testing, but only if medically necessary. While hospital-based physicians may maintain private practices outside the hospital, at the hospital, they are responsible for providing critical services to admitted patients. These include ER doctors, anesthesiologists, radiologists, and pathologists. Most will bill the patients directly, and billing is done on the 1500 or the 837P, and most include the code for the hospital as the place of service. Even if the physician is contracted with the hospital, they may not be contracted with the patient's health plans. Patient may get balance bill for a percent not paid by the health plan and is typically referred to as a surprise bill, as you may have heard often in the news. The no surprise billing legislation that the Florida HFMA chapter just presented on a few weeks ago is intended to address this. In addition to rural health clinics, providers may operate provider-based clinics staffed by physician and advanced practice providers, or APPs, such as physician assistants or nurse practitioners. The Centers for Medicare and Medicaid Services has issued specific regulations establishing the criteria that must be met to qualify for provider-based status. The advantage of provider-based status is the ability to bill both the technical component, which is the facility, and the professional component, which is the physician. From a patient's perspective, a provider-based clinic often looks and feels the same as a physician's office. However, due to the status of the clinic, there would be two claims, a physician and a clinic claim. Thus, the patient could have two co-payments, one co-payment and one co-insurance, or another combination of patient portions. Again, this is a situation where informing the patient the care is being provided in a provider-based clinic versus a physician office setting, as the patient's pay responsibility may be greater than the anticipated. Telehealth. We have certainly seen a huge surge in telehealth and telemedicine this year. It is considered a cost-effective alternative to the more traditional face-to-face. It permits a two-way, real-time interactive communication and the patient. It includes a variety of applications and services, including a two-way video, email, and smartphones. Medicare pays for a limited number of Part B services furnished via telehealth. Some examples are office visits, kidney disease education services, and telehealth consultations. Medicare beneficiaries are only eligible if the originating site is in a rural health professional shortage area, located outside a metropolitan statistical area, or MSA, or in a rural census tract. In response to the COVID-19 pandemic, CMS moved swiftly to significantly expand payment for telehealth services and implement other flexibilities so that Medicare beneficiaries living in all areas of the country can get convenient and high-quality care from the comfort of their home while avoiding unnecessary exposure to the virus. Before the public health emergency, only 14,000 beneficiaries received a Medicare telehealth service in a week, while over 10.1 million beneficiaries have received a Medicare telehealth service during the public health emergency from mid-March through early July. Other health plans and employers are actively incorporating telehealth benefits, in-plan benefits, and health plan contracts. And we're up on our second polling question. Which statement, it's not a unique billing rule to specific providers? And we can go ahead and see the answer. And you all said number one, but I have that the correct answer is number two. The statement refers to a common bill issue with hospital-based physicians that are not contracted with the hospital. Patient has no choice of physician and may receive surprise bills. And some key points to what we just covered. There are common billing requirements in addition to the common claim forms, such as how inpatient days are counted, outpatient series, and inpatient billing and Medicare billing time limits. There are basic billing rules and payment methodologies for rural health clinics, hospice, skilled nursing units, ambulance, hospital-based physicians and clinics. And telehealth or telemedicine services result in the submission of two claims, an originating site claim and a distant site practitioner claim. Next, COVID-19 regulatory changes. In response to this pandemic, CMS has issued a number of waivers and temporary billing rules to avoid or allow providers to bill for services provided to general public as well as victims of the COVID-19 virus. Although commercial payers are not required to follow CMS changes, most have accepted the Medicare changes as an industry standard. Within revenue cycle operations, new billing and coding protocols have been established on a temporary basis. This section will cover the Medicare guidance. Providers should confirm with each of their commercial payers and state Medicaid programs for acceptable billing and coding guidance. Capacity is one issue for specific waivers of CMS regulations. To address this, CMS developed the concept of a hospital without walls. For example, acute care providers may need an ICU or med-surg capacity beyond what they currently provide at their location. The issue becomes when we're to develop excess capacity and what specific billing codes apply. Inpatient care or inpatient level of care provided in an ASC at the DR condition code designated disaster area, and the appropriate ICD-10 coding is required. The main campus provider number attributes are used for the 837I claim. These requirements also apply to a distant part unit within the main inpatient that is converted from the distant part usage to ICU or general med-surg usage during the disaster period. If the unit is used for COVID-19 patients only, the all appropriate ICD-10 codes indicating COVID case is required. If acute care is provided under arrangement with an IRF, psych, or T or LTAC facility, the DR condition, again designated disaster area, and the appropriate ICD-10 coding is required. The main campus provider number attributes are used for the 837I claim. If a patient is transferred to a freestanding IRF or psych or LTAC or other provider that has applied for and received an acute care provider number, the cases would be considered as transfer cases, from the original acute care facility. And the specialty hospital would bill under its own acute care provider. Transfer payment rules would then apply. Services related to COVID-19 testing should be billed as either outpatient laboratory or reference laboratory services using the CS modifier and the appropriate diagnostic and HCPCS coding. Outpatient clinic professional services and predominantly being provided via telemedicine channels and billed under the telehealth or telemedicine waivers provided by CMS. Cost sharing. So for the scenario where patients is tested in an ED, emergency department, physician office urgent care, or other ambulatory location and not admitted to an acute setting, cost sharing for the visit, including the testing, is waived. The CS modifier is used for dates of service on or after March 18, 2020, until the end of the public health emergency. If a patient is treated in the ED and subsequently admitted, the cost of the ED visit and the tests are rolled into the inpatient visit, and cost sharing for the testing is incorporated into the cost of treatment on the inpatient claim. If the patient is tested in the ED and subsequently admitted to observation and the care is billed as an observation claim, the CS modifier is used for the dates of service on or after March 18, 2020, until the end of the public health emergency. If the patient is tested as a result of the direct inpatient admission, the cost of the testing is not waived and testing is incorporated into the cost of treatment on the inpatient claim. Telemedicine services. During the public health emergency, the March 2020 Coronavirus Preparedness and Response Act included a provision to waive certain Medicare payment requirements to make telehealth services available to all Medicare beneficiaries in all areas. Under the waiver, the telehealth service may originate anywhere, including the home. The list of covered services has been amended to specifically designate HCPCS codes paid under the physician fee schedule. Two important billing codes are required in addition to standard telemedicine coding. Modifier 95 indicates synchronous telemedicine service rendered via a real-time audio and video telecommunication system. Some Medicare Advantage and commercial payers are requiring place of service code O2 for all telemedicine services. If the provider is servicing patients in another state, licensing requirements for that state must also be met. And we're up onto another polling question. Which of the following does not apply to billing during the COVID-19 public health emergency? And let's go ahead and see the question, the answer. And so the correct answer is 2, which none of you selected. Telehealth claims are not payable if the patient is at home. That's not a correct statement. They are payable, so this is not an accurate statement. Next, we're on 3.7, and we're gonna be discussing here health plan contracts. We're gonna explain the basic health plan payment contracting options, as well as discuss the components of silent preferred provider organization payments. As the healthcare industry transitions from volume to value, the variety of alternative paymentees is expanding, and the associated financial risk providers will bear is increasing as a result. Alternative payment models are expanding to include coordination of care and quality components. The least risky payment system would be a fee-for-service where a provider is paid for each unit of service without constraint or spending. The highest risk is capitation, where the provider shares savings from better care coordination, but could also have very costly services that erode any profit margins. Health plans negotiate with providers, and call contracts include some discounted payment methodology. They can be as simple as a % discount to complex case rates without outliers. The difference between provider charges and the health plan payment, excluding patient liabilities, is written off as a contractual allowance. Percent off the cost of care is common, perhaps 10%, but from a health plan perspective, there is no incentive to control costs. The per diem literally means per day and do not vary based on the level of services typically used. The pay institutional providers where the level of care is relatively stable. DRGs are a system of classifying inpatients on the basis of diagnosis into clinical similar groups. APCs divides all included outpatient services into nearly 600 procedural groups. The services within each group are clinically similar and require comparable resources, and each APC is assigned a relative payment weight. Fee schedules are typically used for tests such as labs, radiology, based on specific CPT codes. Case rates is a fixed price for specified procedures by paying an agreed upon rate, and is common in cardiology, orthopedics, and oncology. Also transplant services and outpatient procedures. They are appropriate for procedures where the level of intensity and resources consumption is relatively predictable. Package pricing is a payment system in which a lump sum or bundled payment is negotiated between the health plan for some or all of the services typically associated with a procedure, including hospital, surgical, anesthesia, and radiology. This is typically used in cosmetic procedures and sterilization. The Medicare bundle payments for Care initiative is designed to align incentives between hospitals, physicians, and non-physician providers in order to better coordinate patient care. An example is the comprehensive care for joint replacement. Last but not least, capitation is also known as a member per month because the provider is responsible for the enrolled member's health regardless of the cost. The motivation is also to provide preventive care. Silent PPO. So this refers to a situation where health plans do not offer PPO policies, apply PPO discounted rates for patient bills that are not part of the patient's plan. Health plans that do not offer PPO policies obtain the database of preferred provider rates from a PPO or from a middleman called the discount broker. These discounts are applied to claims and the healthcare providers received a discounted payment. As part of the silent PPO scheme, health plans try to pass off the discount as legitimate on the EOB. Typically, the medical provider accepts the health plan statements on the EOB and writes it off, never knowing that the discount was valid. Some providers do put in payment variant processes to find those or a contract with a company that does zero balance reviews to find those. Providers are not required to accept those discounts, but usually the only resource is to balance bill the patient, or the only recourse, which is allowed, but typically results in patient complaints and non-payment. Identifying silent PPO schemes. So examine all contracts and determine if there's room in those contracts for health plans that do not offer PPO discounts. Beware of the following red flags. Health plan is auto or workman's comp. Name of the PPO is not provided. Hospital has no PPO agreement. PPO discount is on the check, but not on the EOB. PPO is identified, but the contract was prior to claim processing. EOB comes on a bill repricing letterhead. If the patient did not mention the PPO during the pre-access processing, that should be a red flag. If a silent PPO continues to take illegal discounts, take legal action. And we're up on another polling question. Which concept is not a contracted payment model? And the answer is you guys were 50-50. The correct answer is actually stop loss provision. So that would be number 3. This common provision found in health plan contracts provide protection for medical expenses that exceed certain levels. And it is also to know when contracts include these provisions to ensure that the additional expected payment can be included when determining a patient's liability. And right before we finish, some key points for this section. There are a variety of provider reimbursement methodologies, such as indemnity or fee-for-service payment, per diem payment, case rate payment, bundled or episodic payment, capitated payment, and fixed contract that can be used in a health plan contracting environment. There are steps that can be taken to identify silent PPO schemes and recover unauthorized discounts and money. And with that, we are at the end of our session and would like to open it up for any questions that there may be. Please remember to always cover the material on your own. These sessions are not meant to be inclusive of your training, and you should spend some time reviewing the material to ensure that you get all the information that you need. And I don't see any questions on the chat. So we'd like to thank you for joining us today, and we hope you have a great rest of your week.